Hi, everyone. Welcome to another edition of Ask the Medical Director. I'm Dr. Aaron Burnett, Medical Director with Regions EMS, and I'm here with my colleague Jen Shea from our Education Department.
We have a lot of really good questions from CME this quarter. This quarter, we're focusing on cardiac arrest. When teaching the Lucas application, the recommendation is setting the Lucas at 30 and 2. This has brought about a lot of discussion. Can you tell me the thinking process that goes along with that?
Absolutely. So one of the cool things about working here in the Twin Cities is that we are truly on the cutting edge of cardiac arrest research. The work we do with Drs. Yiannopoulos and Bartos, who are our ECMO physicians over at the university, really is opening up all new insights into cardiac arrest that we frankly didn't have before. What's really driving a lot of our knowledge is that cardiac arrest patients who we bring for ECMO, the first thing that happens is they get an arterial blood gas drawn off their femoral artery. And that's not something that was really standard of care at all as soon as the patient got to the hospital. Because what that initial blood gas is really reflecting is all the treatments that we've done in the field. We've gotten blood gases on these patients, 10, 12 minutes after hospital arrival, but at that point the gas is really reflecting what's been going on in the hospital as well. With our ECMO program, we can see a blood gas that is purely reflecting what happens in the pre-hospital phase because we get it as soon as the patient arrives at the hospital. What we've seen with these blood gases is pretty interesting. So we've seen a couple trends, one of which is patients who have an endotracheal tube placed as opposed to an eye gel. The patients with the endotracheal tube have a better looking blood gas. Their oxygen level is higher, their pH is a little bit higher, which means their blood is not as acidic. They don't have a metabolic acidosis as profoundly when they have an endotracheal tube. Now, we spent a lot of time thinking about why this might be, but one of the sort of prevailing thoughts that we all agree on right now is that with an eye gel, when you're giving a ventilation and the Lucas is pressing down on the chest, so causing a lot of intrathoracic pressure, a lot of that air probably leaks around the eye gel and doesn't really get into the lungs. So for patients who are getting eye gel ventilation, 30 to 2 was something we sort of decided on right off the bat. And the reason for that is because we want to pause that Lucas device and get 2 full breaths to open up the lungs and really get that oxygenation in. So we agreed on that pretty quick. But then the question was, what should we do with an endotracheal tube? And what we decided is that even with an endotracheal tube in place, we as the medical directors feel it's very important to inflate those lungs fully. And the reason is because your blood flows in a circuit. Flows from the body through the veins to the right side of the heart, through the lungs to the left side of the heart, and at that point it's oxygenated and it gets out to the brain and the tissues. Now, if you think about the lungs as a balloon and they're just compressed, they're just smushed flat from all those compressions, there's not going to be any way to get that blood through the lungs to go from the right heart to get the oxygen to go to the left heart to go to the brain. So even with an endotracheal tube, we think it's worth pausing to get 2 full breaths into those lungs, not even necessarily for just the oxygen those breaths bring, but also because it inflates the balloon, if you will, and allows that blood to go from the right side of the heart through the capillaries in the lungs, pick up the oxygen when it does so, get back to the left side of the heart, and then get off to the brain, which is really the organ we're targeting with our resuscitation attempts.
That's good. That clears that up. So 30 and 2 for everyone.
30 and 2.
That's good. So when teaching wound packing, there's been a great deal of discussion about packing the chest, abdomen, and pelvis. What are your thoughts on this?
Yeah, well, this is a great question. The biggest thing I'll say is the number one key thing to do with hemorrhage control is direct pressure. Tourniquets are important, wound packing is important, but nothing is as important as getting immediate, firm, direct pressure. Once you do that, then you can take the next step to evaluate for do they need a tourniquet and do they need wound packing. Now, the challenge with the thorax, so the thorax and the abdomen, is that you can't really apply pressure to the organs on the inside. Mm-hmm. Even with wound packing, you're never going to get pressure on the liver in the peritoneal cavity with any real effectiveness. Those are what we would call non-compressible wounds, and the only way to stop hemorrhage from those is with surgery. Same thing in the lung. If you get a gunshot wound to the lung or a stab wound, you can pack that external area that's bleeding, but you're not going to put any pressure on that bleeding lung, because that lung is collapsed away from the edge of the wound and caused a hemothorax. So while it may seem nice to pack an abdominal wound or to pack a thoracic wound, it's really not going to get you any hemorrhage control. It's going to be distracting. It's going to introduce some foreign material. And so anything in the thoracoabdominal region is really not going to benefit from packing. Now that's different as composed to a junctional injury in the armpits or the groin, where you don't have a big space like the peritoneal cavity or the pleural cavity that you need to fill. If you're packing a junctional wound in the armpit or the groin, there's nowhere for that packing to go except against the bleeder, because there's muscle and fascial tissue and everything else. It's not what we would call a potential space. The abdomen and the chest are potential spaces, and so packing won't work there. But for the groin, for the axilla, for those junctional wounds, packing can be very effective, and we would certainly encourage it there.
Oh, that makes a lot of sense. And the question we've been asked the most, with the recent legalization of THC gummies in Minnesota, we're getting a lot of questions about if we're getting these calls at the hospital. What are you seeing, and what do you suggest a provider do when they get a THC overdose call?
We do see these at the hospital as well. From a medical perspective, the favorable thing about the pharmacokinetics of THC is that it's not going to lead to a fatal overdose. There's not going to be cardiac instability or respiratory depression. There certainly may be dangerous behavioral activities that could put someone at risk, like running in traffic or something like that. But from a purely medical perspective, the risk of a THC overdose is low. So one resource we have that we would encourage you to use in these situations is the Minnesota Poison Control Center. The Poison Control Center offers a lot of benefits to our pre-hospital providers, but one of them is in situations where there is not a dangerous overdose, Minnesota Poison Control will be able to talk to you and the patient and may be able to recommend that it is safe to non-transport patients in certain circumstances. We also see this with non-marijuana related complaints, such as when a kid maybe finds one of grandma's pills and eats one of the pills and they call 911. That's another great opportunity for you to call Minnesota Poison Control from the scene and discuss the case with them. Now, if they authorize you to non-transport, they're not your official medical direction, so you'll still have to touch base with MRCC, but I can't really imagine a case where one of us as a physician would overrule Poison Control. The one thing that Poison Control does that's very helpful is they will call this patient back and check on them, maybe every hour for 2 or 3 hours to see how they're doing. But they have a built-in follow-up system as well as just giving you guidance. Certainly, you'll have to use your judgment as to whether or not the patient is safe from a psychiatric perspective, because again, people do make bad decisions when they're intoxicated, and those bad decisions can be dangerous even if the ingestion itself is not. But I think we've all seen those cases where somebody has become intoxicated, perhaps on alcohol, for this discussion on marijuana, but they're not psychiatrically dangerous. They're with someone who can care for them. They were afraid because they felt their heart racing or something along those lines. And after you can speak with Minnesota Poison Control, take your vital signs, I think there will certainly be cases where both you as the EMS provider as well as Poison Control as the toxicology expert would feel comfortable in not transporting a patient to the hospital, especially if Poison Control is able to call that patient back, every 30 to 60 minutes for a couple hours and just make sure that they're clearing their intoxication, that they're feeling better. So I think that's a good opportunity, because a lot of times when they do get to the hospital, frankly, we just kind of put them in a quiet room and we let them metabolize off their intoxication for a little bit. So if it's safe to do so at home from a behavioral or psychiatric perspective, as well as from a medical perspective, and Poison Control can help with that medical perspective, I think that's a great resource to consider.
Thank you. We appreciate your time, and if you ever have any questions, please feel free to reach out to one of the instructors or Regions Hospital EMS at gmail.com. Thank you so much.
Thank you.